Respected seniors and dear friends. First of all, I would like to thank the organizing committee of Isacon 2021 for giving me opportunity to talk to all of you. I'm going to talk about current concept for anticoagulants and antiplatelet drugs and regional anesthesia. So we are using more and more regional anesthesia practice in our daily routine practice. It is better for patient outcome and for patient satisfaction. At the same time, patients with anticoagulants and antiplatelet drugs are coming more and more. We are getting more and more patients who are on these drugs. So, and that's why incidence of spinal and epidural hematoma has increased significantly in last few decades, and we need to think about it. So what is the problem? Incidence of spinal hematoma was initially considered as 1 into 1.5 lakh for epidural and 1 into 2.2 lakh with spinal. So this was very old study. But incidence of hematoma has increased with increased use of anticoagulant drugs for things like DVT or PE and antiplatelet drugs for IFT. So incidence has grown as high as 1 into 1 lakh for spinal and 33 into 1 lakh for epidural. And many more studies are coming up where they are showing incidence is quite high if we don't keep the things in mind. So focus should not only on the prevention of hematoma, but also on early detection and treatment of the hematoma. So if as I said, if we look at the literature, there are many reports where they had hematoma after giving clopidogrel or drugs like heparin. Here you can see this is hematoma with lumbar plexus. This is with again with lumbar plexus clot, which is a quite deep lobe. This is spinal hematoma after antiplatelet and heparin therapy. So there are many such reports, and that's why American Society of Regional Anesthesia and many other society like European Society came with guidelines for such drugs. First guideline came in 1998, then in 2002, then in 2010, and latest guideline is 2018. Okay, this guideline is formalized to assist anesthesia provider in decision making for such patients. So common anticoagulant drugs used during the surgical settings are antiplatelet medication, oral anticoagulants, standard heparin, herbal preparation, and new anticoagulants. So recommendations are often pharmacological based. They believe that if you wait for 5 half-lives, then you can give spinal or epidural. So when you are using therapeutic anticoagulation, you have to wait for 5 half-lives. How it helps with first half-life, 50% of effect will go. With second, 25% more, so 75%, and so on. With fifth half-life, with 97% of the effect is wear off. So you can give your spinal or epidural safely. And same way, if you are using it for prophylaxis, then obviously dose is low and you have to wait for 2 half-life interval. Second important point is it is proposed subsequent dosing of antithrombotic therapy based on 8 hours minus the time it takes the anticoagulant to reach peak effect. Why it is considered so? Rosencher look at the study of Boma and Mosnier, who noted that it takes approximately 8 hours for platelet work to become stable. For example, the efficacy of thrombolysis therapy following cerebral embolic clot markedly decrease after 6 to 8 hours. So we know that first 6 hours are golden hour. If we give thrombolytic therapy after 6 hours, then you don't get proper results. So same way, clot is stable after 8 hours. So if you take LMWH, LMWH peak effect is at 4 hours. So subsequent dose should be after catheter manipulation should be given after 8 minus 4 hours, that is after 4 hours. So you may manipulate the catheter, then after wait for 4 hours, and suppose if you want to remove the catheter, wait for 4 hours, and then give LMWH so that there are no chances of hematoma. Thromboprophylaxis, when we need it, we need in many surgery, most of the patient has one or more risk factor for thromboembolism. These factors are like surgery, trauma, cancer, venous compression with hematoma, increased age, pregnancy. So there are many factors which can cause thromboembolism in patient in the postoperative period. So we have to be careful, and we should think of thromboprophylaxis either mechanical or chemical. So risk factors are fashion factor like female sex, elderly patient, abnormal spine, etc. Anesthetic factor are traumatic or needle placement, traumatic spinal or traumatic catheter placement. Epidural technique is more associated with it, and indwelling catheter can cause more hematomas. LMWH dosing is also important. If we start LMWH immediate postoperatively or intraoperatively, then there are more chances of hematoma. So ESRA has given specific recommendation for specific anticoagulants. First, we will go for antiplatelet medication. There are various types like aspirin, NSAID, thienopyridine derivative, platelet glycoprotein, 2B3 antagonists like apiptidamide, tirofiban, etc., platelet P2Y2 receptor antagonists like ticagrelor, and many more. Mechanism of action of aspirin: it blocks cyclooxygenase, and cyclooxygenase is responsible for the production of thromboxane F2, which inhibits platelet aggregation and causes vasoconstriction. So for aspirin, it has got irreversible effect on platelets. So once patient is on platelet, effect will last till the life of platelets, which is 7 to 10 days. So if it is in high dosages, then we have to wait for 7 to 10 days. But in the low dose used for IAD patient, we can proceed for the surgery. And said it inhibits cyclooxygenase, but it has goes reversible effect. So we can wait for a half-life of the medication and then go for spinal anesthesia. So recommendation are for either medication alone, like aspirin does not increase risk. But if you are using along with other medication like clopidogrel, then you have to wait for spinal. No wholly accepted laboratory test for it, and normal bleeding time is not. It does not indicate normal homeostasis. Same way, abnormal bleeding time does not indicate abnormal homeostasis. So we have to look for a history, like history of bruising easily, history of excessive bleeding, female gender, and increased age. These are all factors which can increase the risk of hematoma. A thienopyridine derivative, it interferes with platelet membrane function by inhibition of adenosine diphosphate induced platelet fibrinogen binding. Its duration of action, thienopyridine derivative again exert irreversible effect on platelet function for the life of platelet. So till they get replaced, effect will be there. So what are the ESRA recommendations? Discontinue ticlopidine for 10 days prior to the neuraxial block. For clopidogrel, it is 5 to 7 days, and for prasugrel, it is 7 to 10 days. Thienopyridine therapy may be reinstituted 24 hours postoperatively. So once you do the surgery, once you give the spinal, after 24 hours, you can start it. But if it is used in higher doses, like sometimes cardiologists use loading dose for quick effect, then you should wait for more time. There is no accepted laboratory test for this medication again. Platelet GP3B, 2B3A inhibitors like F6-imab, aptifibatide, and tirofiban. Mechanism of action: it reversibly inhibits platelet aggregation by interfering with platelet fibrinogen and platelet von Willebrand factor binding. For F6-imab, it takes 24 to 48 hours until there is normal platelet function. For aptifibatide and tirofiban, it takes 4 to 8 hours until there is normal platelet function. So guidelines is no neuraxial block should be undertaken until platelet function is normal. And these are contraindicated within 4 weeks of surgery. So once surgery is done, avoid this drug for 4 weeks. If we need to use it in postoperative period in emergency, we recommend the infusion should be limited to the drug minimizing the, so suppose patient is on epidural infusion, then reduce the concentration of the drug so that you can assess the neurological function. Patient will have only sensory effect and no motor effect. Timing of catheter removal is based on ongoing risk of thromboembolism and need for to continue antithrombotic therapy. So we have to look at the risk and benefit ratio and according to take the decision. Warfarin is most commonly used. It inhibits vitamin K formation and depletion of the vitamin K dependent proteins like factor 7, 9, and 10. Its onset is 8 to 12 hours and peak effect will occur in 36 to 72 hours. So what are the recommendations? We have to discontinue for surgical management. We have to discontinue it for before 5 days. We have to assess the INR 1 to 2 before. If it is more than 1.5, then we have to go for oral vitamin K or IV vitamin K. If emergency reversal is required, like for emergency surgery, then we can give higher dosage of vitamin K, like 2.5 to 5 mg, or we can give fresh frozen plasma. If patient has high risk of thromboembolism, we have to think of bridging therapy with low molecular weight heparin. So we should switch to LMWH from warfarin and then go for surgery. Last dose of LMWH should be administered 24 hours before surgery and administer half of the daily dose. Intravenous heparin should be discontinued 4 to 6 hours before the surgery. If there is no risk of thromboembolism, then we can avoid bridging therapy. Postoperatively, we have to resume warfarin in the postoperative day. If patient is put on bridging therapy for minor surgery, resume it after 24 hours, and if a surgery is major with bleeding risk, then go continue after 42 to 72 hours. So for warfarin, evaluate the patient for other medication which can affect the coagulation process. Warfarin should be stopped, as I said, for 5 days before the surgery and check the PTA and INR before giving neuraxial block. Preoperative warfarin, if warfarin has been administered more than 24 hours prior to the patient has been given more than one dose, then check for PTA and INR. Patient receiving postoperative epidural analgesia and warfarin both, then we have to monitor PT and INR regularly, daily. Assess motor and sensory component daily. If the INR is more than 3, then warfarin should be withheld. Epidural catheter should be removed only when INR is less than 1.5. This is very important. If removed with more than 1.5 INR, then we have to monitor the patient neurologically at least for 24 hours. So we have to be careful while removing epidural catheter also. Standard heparin, it binds with the antithrombin 3 and neutralizes the activated factors of 10, 12, and 11, and 9. The elimination half-life is 56 minutes, but if you use higher dosages, then elimination half-life is prolonged, so it is dose dependent. So extra recommendation is mini subcutaneous dose. We don't need to worry, like 5,000 units subcutaneous daily, twice daily, no contraindication. But with higher doses, we need to do enhanced neurological monitoring in patient with epidural catheter. Patient on heparin for more than 4 days, we have to look for thrombocytopenia because it causes thrombocytopenia. So if patient is on heparin for 4 days or more, then check platelet count before going for spinal. Heparin administration should be delayed for 1 hour after neuraxial blockage. So suppose if you are giving heparin in the vascular surgery patient, after giving spinal, give heparin only after 1 hour. Indwelling catheter should be removed 2 to 4 hours after the last dose of heparin and evaluation of PTT. Heparin should not be reinitiated until 1 hour has passed. So stop heparin for 2 to 4 hours, then remove the catheter, then wait for 1 hour, then only start heparin again. If bloody tap has occurred, communicate with surgeon. No need to postpone the surgery. If bloody tap has occurred, then monitor the patient post-operatively for neurological function. There are many LMWH. Enoxaparin is most commonly used drug. Chances of hematoma is more in female gender, elderly, traumatic needle catheter placement, and indwelling catheter when you are using LMWH. So risk of hematoma, as I said, it increases up to 1 into 3,000 for epidural and 1 into 40,000 for spinal anesthesia, especially when you are doing LMWH and not following the guidelines. So mechanism of action, it affects factor 10. LMWH does not alter the patient's PTT, and there are no laboratory tests to measure its action. So patient is an LMWH, and if we do PT or INR or FPTT, it is of no use. So what are the recommendations? General SRR recommendations: assess the patients for concomitant medication that affect the coagulation. Blood retap does not necessitate the cancellation of surgery. Communicate with the surgeon. LMWH administration should occur 24 hours after the bloody tap. Don't give LMWH if you find the bloody tap for 24 hours at least. LMWH should be held for 12 hours prior to the neuraxial blockage. So if we have put the patient on LMWH, then we have to stop 12 hours prior to the neuraxial blockage if it is in normal dosage. If it is in higher doses, like for enoxaparin 1.5 mg per kg every 24 hours, or dalteparin 200 units per kg every 24 hours, then we should wait for 24 hours. For twice daily dosing, the first dose should not be administered until 24 hours after the block. Indwelling catheter should be removed prior to the initiation of LMWH whenever possible. If a continuous technique is used, then the catheter should be removed the next day with the first dose of LMWH occurring at a minimum of 4 hours after the catheter removal or after 12 hours of the last dose. So if patient is put on LMWH postoperatively and patient has catheter in situ, then after giving last dose of the LMWH, wait for 12 hours, remove catheter, and restart the LMWH 4 hours after removing the catheter. Thrombolytic and fibrinolytic medication, we need it in emergency situation. If it is used preoperatively, then the neuraxial blockage is contraindicated for 10 days. No data concerning the length of time that neuraxial block should be withheld are there. If patient need it postoperatively, then we have to monitor the patient for neurological complications. Newer anticoagulant agent like Fondaparinux, antithrombotic medication, it is used for DVT prophylaxis. It binds with antitomin 3, which neutralizes the factor 10N. Its peak effect is in 3 hours with half-life of 17 to 21 hours. It has got irreversible effect. It needs further clinical experience to formulate guideline. Newer anticoagulants like bivardirudin, levetiracetam are also used nowadays. Caution is advised in such patients. Oral direct thrombin and activated factor 10 inhibitors like dabigatran, itaxilate, and RIVAROXABAN are nowadays routinely used for DVT prophylaxis. Dabigatran has half-life of 8 hours after single dose and up to 17 hours after multiple dosages. RIVAROXABAN elimination half-life is 9 hours and 30 hours in elderly patient with altered renal function. So guidelines is for RIVAROXABAN, we suggest that it should be discontinued 72 hours prior to the neuraxial block. Consider checking anti-factor 10 activity level if less than 72 hours. We need to give spinal, then check the anti-factor 10 activity. We suggest that neuraxial catheters should be removed 6 hours prior to the first dose in the postoperative period. And with unanticipated administration in the postoperative period with indwelling catheter, we suggest that RIVAROXABAN dosing be held for 22 to 26 hours before or anti-factor 10A assay should be done before catheter is removed. Same way for apixaban, 72 hours prior, it should be stopped. Neuraxial catheter removal 6 hours prior to the first dose, and if we give earlier, then we have to wait for 26 to 30 hours before removing the catheter. Dabigatran again 72 hours if creatinine clearance is 80 ml or more. If it is less, then it is duration is more, and if it is less than 30 ml per minute, creatinine clearance less than 30 ml per minute, then we should avoid the neuraxial blocks. It is suggested that the catheter should be removed 6 hours prior to the first postoperative dose, and unanticipated administration we have to wait for 36 hours. For herbal preparation, there are many like garlic, ginger, feverflu, ginseng. These are the drugs which affects the platelet function. So if patient is on such medication, there is unknown risk. Most patient advised to stop for 5 to 7 days prior to the surgery and screen for concomitant use of medication that alter the coagulation. Assess the patient for bleeding tendency. If it is there, then we have to wait or avoid the spinal. Now, most important part, epidural hematoma, how to diagnose and treat. It is very important to diagnose it early. If patient complain of sharp and irritating low back pain, patient has sensory and motor loss, bowel and bladder dysfunction, and paraplegia, then we have to think of epidural hematoma. MRI is the diagnostic test for diagnosing it. If it is not available, then we can think of CT scan or myelogram. Treatment, if it should be done within 8 hours. If we delay the treatment, then there are chances of permanent damage. Emergency decompression laminectomy should be done and hematoma should be evacuated. Factor affecting recovery is size and location of hematoma, speed of hematoma development, and severity and nature of pre-existing neurological problem. So if size is bigger, then more chances of permanent damage. If speed of hematoma formation is faster, then chances of delayed recovery or no recovery, and pre-existing neurological problem also affected. For peripheral nerve blocks, there are reports of psoas compartment hematoma and after lumbar sympathetic block, but these are the expandable compartments. So recovery chances are more as compared to neuraxial block. There are reports of hematoma with axillary, infraclavicular, supraclavicular, and interscalary blocks also, but they are very few, and permanent neurological damage is very rare. Risk can be lowered with ultrasound guided block, especially in trained men. If the anesthetist is not trained enough, and then hematoma can occur even with ultrasound guided technique. So if we look at the risk of hematoma with various block, like it is lowest with local infiltration, then superficial blocks, then facial blocks, then superficial perivascular block like femoral, popliteal, or intercostal block, deep blocks like celiac block or lumbar plexus block, risk is higher. If we go for paravertebral block like lumbar plexus block, risk is even higher, and if you give epidural, risk is highest. So this is the guideline when to go for when to go for catheter manipulation after giving various drugs, and time after puncture for manipulation or removal of the catheter, when we can restart it. This is available in ESRA guideline, and it is freely available on website, so you can download it. So take home message is concurrent use of coagulation altering medication may increase the risk of bleeding without altering coagulation studies. So multiple medication, more chances of hematoma. When providing postoperative analgesia with an epidural, or use opioid or dilute local anesthetic to allow neurological evaluation. So if you are using epidural for postoperative pain relief, then use low concentration of the drug or use opioid along with it, so that you can have assessment of motor function. Remove catheter at the nadir of anticoagulant activity, and do not give additional anticoagulant immediately after removal. Follow the guideline properly about catheter removal. Frequent evaluation of the neurological status of the patient should be pursued for early detection of the epidural hematoma and the treatment. If you detect it early, then there won't be permanent damage. In high risk cases, continue monitoring neurological status for 24 hours post catheter removal. So these are the all important points. If you keep it in mind, then you can avoid damage to your patient. Thank you very much. If you have any question, you can ask.